Assalamu alaikum wa rahmatullah. Hi everyone. This is Muhammad Abu Salam, staff nurse in pain management service team at Al Wakra Hospital. I hope you are all doing well. Today I will going to discuss the most interesting topic regarding the nursing assessment and the management of patients with the patient's control epidural analgesia PCEA. First of all, I don't have any conflict of interest, and please follow the COVID-19 precautions. So let's start with introduction. Acute pain is used as a health alert for human beings that could inform them of potential or actual health problems. Pain is lead to unpleasant feelings and negative consequences for patients' lives. Both of these statements, they are derived from the pain definition that pain is unpleasant sensory and emotional experience associated with actual or potential tissue damage. Now, pain assessment and management is integral part for nurses to improving the quality of patients' care. This my words. This activity will enhance the nurse's ability to predict and prevent and management patients who are receiving pain medication via PCEA. I mean by predict this problem that might be developed with those patients who are receiving medication via epidural. Once the nurses they are starting to predict this problem, they will do the best to prevent and even happen, he or she will do the best to prevent the harm on the patient's body. Learning outcome at the end of this presentation, the nurses will be able to identify correctly the patient's control epidural analgesia definition, indications, advantage, and contraindications, perform a comprehensive nursing assessment steps during the care of the patients with PCEA, explain all the critical signs and side effects that might develop, implemented and evaluated the management options to treat the side effects of the PCEA. Finally, we need to recognize the nurse's role before and after removal of the epidural catheter procedure. So, okay, the outline in this lecture, I will going to cover the anatomy of epidural space, definition of PCEA, indications and contraindications, local anesthetic medications, nursing assessment, critical signs, side effect and management, pre and post removal, the epidural catheter assessment, finally documentation. So let's start with the anatomy of the epidural space. Actually, we can say or we can imagine this is the patient's back, and when the anesthesia doctor or when the anesthetologist need to introduce by the epidural needle will reach to the interspacious ligament. After that will reach to the ligamentum flavium. Now we have a three meninges that covers of the brain and the spinal cord. The first layer is called dura mater. Now the space between the dura mater and ligamentum flavium, it's called epidural space. Epidural space is a potential space with a negative pressure that's filled with the fat, blood vessel, and so on. We move on, we reach to the second layer, it's called arachnoid mater. Between arachnoid mater and dura mater, there is a potential space as well, is called subepidural space. Third one is called biomater. Now, between the biomater and the arachnoid mater, there is a subarachnoid space that's filled with the CSF, cerebrospinal fluid. Finally, spinal cord. Now, this is our target, to reach to the epidural space and place the catheter there. Okay, this picture shows the proper patient position for insertion the epidural needle and epidural catheter, and the proper position is the sitting position, but sometimes the anesthetologist is going to do this procedure on the lateral position with pregnant woman. Now we need to know how we can decide that site for placement the epidural catheter on the patient's back. Actually, the anesthesiologist, they're going just to choose this area depend on the surgery itself. That means which area he or she need just to cover. So the site for epidural catheter placements depend on the type of surgery itself. Now, what is the definition of the patient's controlled epidural analgesia? Actually, it is a computerized infusion pump, is a highly effective mechanism for controlling acute pain following the surgery or trauma to like a chest, abdomen, pelvis, or lower limb. Finally, and this is a very important, and many of the literature that are talking about that, like it gives the patients the power to self-administer the analgesia of the medication. Okay, now indications and advantages. Let's start with the indications. During labor, in normal delivery, they are using widely there. Some of, or after some of a painful surgical procedure like abdominoplasty and fracture, burn patients, cancer patients. But actually, in the cancer patient, there is something sound difference, because when I discussed the previous slide for using the PCEA, we are using the PCEA for acute pain, but the cancer is a chronic condition. So even the patient has a chronic condition, sometimes he has a spike of acute pain, like after of surgery. So we need just to recognize even the patient has a chronic condition, sometimes he or she has a spike of acute pain. Now, advantages. Actually, as we know before, the pain is unpleasant sensory and emotional experience. And if the pain is untreated or undertreated, that causes harmful on the patient's body. So we need to treat it or at least cover it. So what is these advantages? First one is reduce the stress level, right? Because the pain, it will increase the stress level, decrease the length of the hospital stay, enhance the gastrointestinal function, decrease the opioid use, increase patient satisfaction, and this is very important, and reduce nursing workload, because the PCA, it gives the power for the patients to control their pain. Now, there is some of the contraindication, like if the patient refuses, and that's considered as a patient's right, some of coagulopathy, because it has some of the consequences to develop of the epidural hematoma, increase of the intracranial pressure, some of the allergy, local site infection, because might be having, might be developed to the meningitis, and some of the PAC surgery like laminectomy. This picture is show the infusion set for PCEA that come with the yellow color and spike set. In the second one is show the PCA machine with a yellow color as well with the button. So the nurses must be check on the compatibility because it's a code color. Also, the nurses must be check on the PCA mode. Actually, we have three different type of PCA mode. The first one is a PCA, which is mean bolus. The second one is continuous. The third one is PCA plus continuous. Also, the nurses must be check on the PCA parameter, demand, given, and lockout time. Also, the nurses should be check on the total amount of medication infused, what is the remaining, and battery status, and inform the pain team or anesthesia department about anything. Okay, this picture is show the HMC protocol for medication and PCA parameters. I will just discuss the medications without the parameters, because the parameters it will change from the physician to the other. The first two medication they are using in our hospital, the first one is called ropivacaine and the second one is called levoprovocaine. Both of them are new generation from the old local anesthetic medication is called bupivacaine. Actually, the new generation of local anesthetic medication is less in toxicity in cardio and in neuro, and with long acting. There are two adding medication. We can add the clonidine. Clonidine is alpha-2 agonist, mainly used as antihypertensive medication. But here we can add it to the levo to prolong the levoprovocaine effect. But some of the anesthesiologists doesn't like to use because it causes the hypotension. And the second one is the fentanyl. Fentanyl is one of the opioid. It has a potency more than morphine 100 times. We can add it to the levo to increase the potency. And this mixing between the levo and fentanyl is used only for labor units. So what about the nursing assessment? We need to start with the vital signs and assess the sedational score, level of consciousness, pain assessment by using the PQRST, nausea and vomiting score, sensory assessment block by using the and motor assessment block by using the Bromage scale, and check on the side of the insertion. This is just a list of the nursing assessment, and we will discuss in specific, or I will go through with each one. The first one is a monitoring. Actually, the pain score, sedation score, and vital signs demand. I mean by demand, that's a number of the attempt and a given the number of injection. We need to start the documentation with 15 minutes for 1 hour, every 1 hour for 4 hours, then 4 hours until the PCA discontinue, and we need to document the 4 hours after the PCA discontinue. Other things like a nausea score, sensory and motor, epidural block, prescription, we can check just every 8 hours, which is mean once per shift. The next part is the sedational scale. Actually, the sedation is the scale is rating from 0 to 3 with S, that means sleep normal. 0, that patient is alert. 1 is mild, is easy aroused. 2 is moderate or difficult to arouse, or we can say if the respiratory rate less than 10. Now, what is the difference between the easy aroused, which is mean mild, and moderate? Now, easy aroused, that's mean when I'm with the simple talking with the patient is become awake and become aroused. But in the difficult, we need to apply some of the physical forces to the patients to arouse the patients, like sternum pressure, trapezius grabs, or suborbital. Finally, or 3 is severe, which if the patient is become totally unresponsiveness, or if the respiratory rate less than 8. You should to contact immediately with the anesthesia department if the sedation is scale 2 to 3. Now, this is the Bromage scale. This is the motor block assessment. is rating as well from 0 to 3. 0, that's the patient's able to full flexion the feet and knees and elevated. From age 1, just able to move the knee. 2, able just to move the feet only. 3, the patients unable to move the feet or knees, and some of the patients, they respond or they saying, I feel a heaviness in my leg. Actually, this scale you should to cover the both side, right and left, and you should to document it as well on the Cerner. Now, this is the dermatomes. The dermatomes looks like a map in our body. We need just to pick up that 2 points the patient doesn't have feeling between them. So what is the meaning of the dermatomes? Dermatomes is a single space or the single area of the upper body is innervated by the single spinal cord or spinal nerve. When you're doing the assessment, we need to start with the one area that's well away from the blocked dermatomes, like a forehead or the shoulder. I like the shoulder to use it in that practice. And there is some of the landmark that help us to identify or to clarify the area in our body. Let's start with the first one. Nipple line, it's called T4 nipple line. That comes between the nipple. The T6, that's xiphoid process. T10 is umbilicus level. T12 is inguinal ligament. L1 is the hip and groin area. L3 is the knee. This is a landmark that helps us during doing the sensory assessment block. Okay, I have this video that helps us just to clarify or just to identify how we can do the sensory and motor assessment. Please listen carefully about her procedure.
Good morning, Ken. My name is Jill. I'm with the Pain Management Service. I've come to see you because you had your operation yesterday and you've got an epidural, and we just want to see how well that's working for you. So I'm going to do the ice test, and I'm also going to check your motor function to see how that is. Okay, so you can feel that it's really cold?
Yes.
Okay, so I'm going to touch you on your body, and I need you to tell me when you can feel it that cold. Okay, so we'll just start on this side first. I'm going to start about where you've got the epidural in. So, can you feel that cold?
No.
Okay, coming up.
No. No. Starting a bit colder?
Yeah, but not as cold as that?
No.
Okay.
That's colder now?
Yep. As cold as your head?
Yes, thereabout.
Okay.
Just as cold as my head.
Alright. Okay, I'm just going to come down this side of your body. So,
Yep.
can't feel it?
Starting to get a bit colder
A
now.
little bit colder?
Just a bit more
Yep.
than what it was just now?
Is this as cold as this?
No. Yep, it's as cold as my head.
It's cold down there now.
Yep.
Okay. Okay, so remembering how cold it is,
Just starting to feel it now.
starting to feel it. Yep.
Much colder.
Much colder.
And yeah, it's
That's really
pretty
cold there now. Okay, so I'm just going to come here. Okay, can you feel that cold?
No.
No? Let me know when it's cold.
Starting to feel a bit colder.
Yep.
It's much colder now.
Okay,
And yep,
cold there
it's
now.
pretty cold there.
Okay, so we've got a block from T4 to L2. Excellent. While I've got that leg exposed, can you show me, can you wiggle your toes? Can you flex your ankle? And can you lift your leg off the bed? Beautiful. Okay, and on this side, I'll get you to wiggle your toes. And can you lift your leg off the bed? Beautiful, that's lovely. And just get you to squeeze my finger. Beautiful, as tight as you can, lovely. And this one, nice and tight. And you're able to lift your arms above your head. Beautiful, lovely, excellent. Good.
As we you, her finding of the block, it was from T4 to L2, and she also examined the upper limb. Actually, they examined the upper limb by asking the patient like to squeeze the hand or either elevated the hand, especially if the epidural catheter is placed at the thoracic level, because one of the common sign and symptom for high block is like a numbness of the hand and some of the lips numbness. So we need always to ask the patients about any other sign or any other discomfort they have feeling. So in this slide I will start just to discuss that a sign and side effect that might be developed with those patients who has the PCEA. I will divide it to the both sides. The side effects related to the local anesthetic medication like respiratory depression, hypotension, bradycardia, oversedation, hypertension, pruritus or retching, nausea and vomiting, dense motor block, and constipation. Before we start, just I need to focusing on the most important two steps of the management. The first one is stop the PCEA infusion. So the first management for all of the side effects is stop the PCEA infusion. The second one, we need to start with the quick APC assessment, airway, breathing, and circulation. Don't forget those two most important points during the management. Now, respiratory depression. According to our policy, if your patient's respiratory rate is less than 8, that means respiratory depression. There's other indicators like if the oxygen saturation level is low and carbon dioxide level is high. Now, what is the management of that? We need to call for help immediately based on the patient's status. For example, if the patient is still awake but if the respiratory rate less than 8, so I will call RRT. That's totally different with someone who's become unresponsiveness, so I will activate the coded blue. That's what I mean by based on the patient's status. We can put in the patient in semi-sitting position if the patient is still awake, just to allow the medication to go down. This is because the epidural space has minimal effects of the gravity, and all of the medication of the local anesthetic medication they are using is affected by the gravity because it's hyperbaric. So when I put the patient in semi-sitting position, that allow the medications to come down and not exceed more than dermatomes. We need to start with connected the patients with the cardiac monitor. We can provide the oxygen, call the responsible team. Last option, we can use the naloxone. Actually, the naloxone might be helpful just if the local anesthetic medication mixing with opioid.
Side effect is hypotension. The most commonly of the hypotension that comes from the vasodilation. What is the causes of the vasodilation? The vasodilation is come from the epidural relax the muscles in the wall of the blood vessel. The second one, most commonly of the local anesthetic medications, they are blocking the sympathetic. Once the sympathetic are blocked, so the parasympathetic started, that causes the decreased venous return and decreased cardiac output. So what is our management? After stop the infusion, start with APC, we need just to call the responsible team immediately. We need to put the patients on the monitor, and this is very important. Some of the physician likes to start with the IV fluid, but if the IV fluid is not helpful to bring back the blood pressure to the normal level, we need to start with the IV medication as per doctor order. The most common medication is called Epidural. We had bradycardia. The causes of the bradycardia, the first one might level of the block exceed to T4 that reach to the myocardium. That also causes to decrease the cardiac output, and this is a serious condition. Second one, bradycardia sometimes that comes as a late symptom related to some of the medical issues like fever, vasodilation, stress, and hypovolemia. Now, according to the compensatory mechanism of our body, they react these medical issues, the first one with the tachycardia. Now, if the tachycardia is not treated well, the body will go down or will go to the bradycardia. So the bradycardia is sometimes it comes as a latest sign. So what is the management? We need to call for help immediately. Put the patients on the cardiac monitor. Now, if the patient is still awake, we need to put the patient in semi-sitting position and call the responsible team. Oversedation actually is a very, very rare between those patients who are receiving the painkiller via epidural, but we need to discuss it, or because sometimes it's encountered, I don't know. So the first question, just to explain this sign, what the part of the brain contains the respiratory sensor is a medulla oblongata. The second question, what is the causes of the oversedation? Actually, the causes of the oversedations between those patients who are receiving the analgesia via epidural, that mean the medication or local anesthetic medication reaching to the medulla oblongata. So the medulla oblongata is become anesthetized. So there is no respiratory at that time, because the oversedation is a sensitive indicators of respiratory depression. The management call the help immediately based on the patient status. Most commonly, we need to activate the CPR or activated the code blue, connecting the patients to the monitor, provide oxygen, provide oxygenation, and we need to inform the responsible team. Urinary retention. What is the causes of urinary retention? The local anesthetic medications in general inhibit the volume, induce bladder contraction, and block the viscosomatic reflexes required for sphincter relaxation. And we can summarize that by saying that a local anesthetic medication are blocking the afferent, which is mean the sensory, and efferent, which is mean motor. So the patient doesn't have a sensation for urgency to go to bathroom, and he cannot have the ability to relax the sphincter. Actually, this problem or this side effect is common between those patients who has a prostate problem, so on the man more than 50. So we need to recognize that when you're doing the epidural catheter for those patients. The management, actually, we need to go to urinary catheterizations, and it's become a recommendation for those patients during receiving analgesia by epidural. Okay, pruritus or itching, actually it's very rare, but might be happen with some of patients related to the histamine release. As our nurses, we need to ensure that there is no angioedema in the vital area like faces or neck and upper thoracic,
because the angioedema, it will block the airway. So the management will start with call the responsible team. We need to connect the patients to the cardiac monitor, and the treatment of pruritus, it will be depend on the severity. I mean by the severity, in mild cases, no treatment, just simple reduction in the infusion. And in severe cases, we need to follow the anaphylactic shock protocol. Nausea and vomiting actually less happen with in the PCA epidural than PCIV. Why? For three things. Actually, the epidural is a local, not like IV systematic. We used a small doses, and we use also a local anesthetic medication, not opioids. Now, why the opioid is called opioid-induced nausea and vomiting? Actually, the opioid or activated the chemo zone in the brain, serotonin and dopamine receptors that induce nausea and vomiting, especially for naive patients. Naive, that's mean who has those patients receiving the opioid in the first time. This is totally different with the local anesthetic medication. But if the incidence might be increased if the patient receiving some of the opioid like fentanyl with local anesthetic medication, hypotension, and increase of stress level. Now, the management is simple. We need to call the responsible team. We can start with the anti-emetic medication as a per doctor order, like metoclopramide, ondansetron, and IV dexamethasone. Dense motor block is considered one of the most important side effects, and we need to understand it. Now, I mean by the dense motor block that the probability score is 2 to 3. Okay? Now, the motor block is common immediately following the surgery due to the higher dose of the local anesthetic medication that used during the surgery, especially also with the patient receiving a combined between the spinal and epidural anesthesia. Now, excessive motor weakness may indicate to high rate of the epidural infusion. Why? Because there is a clear rule of using of local anesthetic medication that mentioned a concentration of the local anesthetic medication has a direct relationship with the intensity of the sensory and motor block. So when I increase the concentration of the local anesthetic medications, they allow to cover a sensory and motor nerve. But when I do the quiet dilution of the local anesthetic medication, I allow just to cover the sensory without motor. This picture we can see clearly in the gynae room. During normal delivery, the woman, she can able to do bear down without painful. Now, bear down is movement and painful is sensory. That's what we mean by free of pain. So, what we can do related to the dense motor block? Simply, the first one, all dense motor block after the epidural insertion must be reported to the anesthesia department. Why? Because most commonly of the dense motor block, they are coming from the serious conditions. This is what I mentioned in the second point. So as our nurses, we need to continuous assessment and monitor by nurses and pain team staff. They exclude any other serious consequences like epidural abscess and epidural hematoma. Both of them I will discuss later. Constipation. As I said earlier, no constipation like nausea and vomiting, less in PCA epidural than IV. The incidence might be increased if the patient receives fentanyl with local anesthetic medication. It comes with loss of activity as well. So what is the management? We can put the patient on laxative prophylaxis, early mobilization, increase in fluid intake. Second part is epidural needle and catheter side effect.
So the first one is epidural site infection or epidural space infection and abscess, epidural hematoma, post-dural puncture headache, epidural catheter migration, finally nerve or spinal cord injury. The last one, nerve or spinal cord injury, is very rare, so I will not go with it. Now, we will start with the epidural site infection, space infection, and abscess. So what is the sign and symptom? Back tenderness at the site of the insertion. Actually, one of the most important rules to the nurses, just to clarify, if this tenderness that comes normally from the insertion or there is any other sign. Increase of the body temperature, pyrexia. This is indicators for infection. Any bleeding, any bruising, swelling, redness, or drainage at the site of the insertion. We can use some of the lab tests that help us to clarify or identify any infection like ESR or CRP. Now, what is the management? We need to inform, call the responsible team. We have a two type of culture. Swab culture for site infection, for epidural site infection. Now, if the doctor decided that infection that comes from the epidural space, we need to remove the epidural catheter first, then we need to cut the tip of the catheter and send to the lab for culture. Monitor the vital signs. We can start with cold compresses and antibiotic medication if there is any fever. Start with as soon as possible with broad antibiotic and routine monitor of epidural site as or based on the HMC policy. Epidural hematoma. There are some of risk factors that help for develop like epidural hematoma. The first one, if the patient's on anticoagulation therapy, if he or she has a difficult needle during the procedure or in the catheter insertion, thrombocytopenia, which is mean low platelet count, or congenital abnormality like hemophilia. So the sign and symptom, the picture, it's come with the severe lower back pain with no motor and sensory. Because that if the patient has a dense motor block, they should report it to the pain management team or to anesthesia department to go further or to go deeply to see if it's that coming from the epidural hematoma or epidural abscess or just that comes from the increase of the medication concentration. So simple the management, this is management for the nurses. We need to close monitor for motor and sensory block assessment. We need to call the responsible anesthesia doctor to inform them, as I said earlier, and we need to do the MRI and neurosurgical consultation if anything happens. Okay. Post-dural puncture headache. Most commonly of the nurses, they say that post-dural puncture headache is a normal side effect follow the spinal or even the epidural procedure, and this is totally wrong. This is a side effect and we need to inform to pain team or anesthesia doctor to start with the treatment. Now the picture is the headache usually begins in the occipital regions and radiated to the frontal and orbital region. The pain usually becomes worse if the patient sits up or stands. The pain may be combined with some of sign and symptom like nausea, vomiting, sweating, dizziness, stiff neck, and stiff neck is common, photophobia, and double vision. So what is the management? We need to start with the inform the responsible anesthesia doctor or pain management, as I said earlier. We need to start with a bed rest and good hydration and caffeine. Simple analgesia such as paracetamol. If those management are not getting helpful for the patients, we need to go to do some of the procedure. It's called epidural blood patch. Epidural blood patch is done by the anesthesia department or by the anesthesiologist.
Epidural catheter migration. What I mean by the migration? Actually, the catheter tip can exist the epidural space via an intervertebral foramen and giving rise to unilateral sensory block because it's affected just only one side. And this is most required to contact with the anesthesiologist. So when it comes to assess the patients, for example, I will see the patient doesn't have feeling in the right side, for example, and he has feeling on the left side, so which is mean this is unilaterality. This is that comes might be from because the catheter tip exists the epidural space to the intervertebral foramen. Now the catheter tip might be migrated into the other places like or as intravascular, subdural, subarachnoid, or subcutaneous, but it's considered very rare, so I will not go with that. The catheter should always be aspirated by the anesthesiologist, actually aspirated and assessed by the anesthesiologist to verify correctly placement prior to administer local anesthetic medication. So after placement of the catheter, we need to do some of techniques like aspirate or inject of the epidural just to clarify if the placement of the catheter is correct or incorrect. Now this is a picture just show what I mean by the intervertebral foramen. Look, this is the intervertebral foramen, like a hole that allow the spinal nerve exists from the spinal cord, like an opening. So sometimes the epidural tip stuck here on the right or on the left, and bulk of the medication they affected one side. We need to talk about the management of the epidural catheter migration. So the first one, we need to go to stop the infusion. We need to go to inform the responsible anesthesia doctor. Also, we need to change the patient position. Now, let us just to explain this statement, I mean number 3, change the patient's position. Now, regarding the anatomical of the epidural space, it has a minimal effect of the gravity. Also, the local anesthetic medication is affected by the gravity because it's hyperbaric. Now, if the patient has unilaterality, that's been affected one side and is not affected other side, so we need to turn the patients from the affected part to unaffected part. So for example, let's say if the patient doesn't have feeling on the right side, but he has feeling on the left side, so we need to move or turn the patients from the right side to the left side. And now the catheter dressing should be assessed routinely to confirm that it's dry and intact. Finally, we need to assess the sensory block to discover if the level of the block is raised. Now we need to start with the removal of the epidural catheter. So I will discuss before the procedure and after the procedure. So the first one is before the procedure. Before the procedure, we need to maintain the IV access or peripheral IV access before and after the procedure at least 6 hours. Now, the epidural catheter should be removed under sterile conditions, same insertion. Now, we need to hold the anticoagulant medication due dose before and after the catheter removal as per doctor order, and this is very important statement here. And for example, according to the HMC policy, we need to wait 12 hours after the last dose of the low molecular weight heparin like enoxaparin or deltaparin prior to remove the catheter. and we need to resume the medication after 6 to 12 hours after the catheter removal. Now, this is related to the low molecular weight heparin. There is a clear statement for this medication. But why I put it as per doctor order? Because there is other anticoagulant medication like heparin and warfarin. Now, regarding the warfarin, it's become depend on the INR result, and regarding the heparin related to the APTT result, related to the site of the injection, also related to the dose of the medication. So for this medication or others, we need to receive a clear order from the doctor, how many hours we need to hold and how many hours we need to wait to resume the medication. After the procedure, remove the epidural in the gentle way and don't apply the forces. Ensure the blue catheter tip is intact. This is the tip of the epidural catheter. We need to assess the insertion site for bleeding, bruising, swelling, redness, or drainage. Finally, in the normal situation, after the epidural catheter removal, the patients can have their motor reflexes back without sensation at the first, then the sensation will come after. So we can say the motor reflexes will come first, then the sensation. Okay, to explain why the motor is coming first and the sensory is coming after, look at this picture. We have two different types of the nerve fiber. The first one is myelinated with myelin sheet, and the second one unmyelinated. The first one is responsible on motor and is called motor nerve fiber. The second one is responsible on the sensory and it's called sensory nerve fiber. First of all, local anesthetic work by blocking the nerve impulses on the sensory and motor, right? The second one, the local anesthetic medication, they are sensitive on those nerve fiber are smallest diameter. So here in this picture, the sensory nerve fiber is smallest than motor. So the local anesthetic medication, it will become sensitive on this nerve fiber. The second thing, actually, in the first one, in motor nerve fiber, there are a myelin sheet. Myelin sheet is to protect the nerve fiber. So the local anesthetic medication is not deeply affected with motor. This is totally different with the second one because the sensory nerve fiber without myelin sheet. So the local anesthetic medication will deeply affected like this nerve fiber. So after discontinuation of patient's controlled epidural analgesia, the motor nerve fiber will come first, then the sensory will come after. In documentation, we need to document the time and date and time of removal. We need to document also the person who removed and the witness during removal, condition of the catheter tip, drainage, bleeding, or hematoma at the catheter site, patient tolerance of the procedure, sensory and motor function tests, complication and interventions. And we have some regarding the summary. Patients control epidural analgesia provides effective and safe post-operative analgesia on the hospital wards. Yes, even we after discuss the side effect, and most of you are upset right now, but the patient's control epidural procedure or epidural analgesia procedure is considered the safest procedures to cover the acute pain follow the surgery. Now, related to our role as a nurses, the nurses are playing a vital role in the patient selection and maintaining the delivery system safe and secure. In assessments, ability to their own needs for pain management, start the frequent pain assessment and patients education. reduce the side effects by continuous monitoring. This is the point cause. Pain is such an uncomfortable feeling that even a tiny amount of it is enough to ruin every enjoyment. Finally, if you have any question related to our subject, you can just write it down in the comments. This is a list of reference I was used. If you would like to go with each one just to read more, you can. Finally, thank you for your kind attention and goodbye.